how does sludge look? We see it over here, the gallbladder. It's not totally dark, not totally black. There are hypoechoic echoes in this region. It's marked over here. And when bile has been stored in the gallbladder for a longer period of time, it may become thicker and then appear in the form of sludge. Often gallstones will develop from this sludge. Sludge is also a sign of a reduced function of the gallbladder and a blocked drainage. So on the next clip you will see two problems. Here we see the sludge. Patient was lying in a supine position, so we have this horizontal border of the sludge in this region. And when we take a close look to the liver and the bile ducts, we see dilated bile ducts. But we're going to talk about this later on. Okay, let's go to the next chapter. Tumors of the gallbladder. We can see benign tumors or malignant ones. The most common benign tumor of the gallbladder is the adenoma. Frequently, we see polyps on the wall of the gallbladder. They ought to be examined regularly in future, because if they are larger than 10 millimeters in diameter, or if they increase in size rapidly, it's recommended that the gallbladder should be operated. It's not so easy to differentiate between the benign tumors, so we are only going to look for polyps, and we see there is no posterior acoustic shattering, and they're attached to the wall, even if the position of the patient is changing. Over here again we see a polyp, but it's not so easy to say this is a polyp and not a stone. So we have to look for the criteria. It's attached to the wall, it remains on the same segment of the wall while changing the patient's position. We see this in the clip. Over there, a polyp on the wall over here. And then the next one, we're going to the transverse plane and also see attached to the wall a small, tiny hypoechoic structure over here. And in this particular case, there's not one, there are dozens of them. Here and here and here. When we look on this polyp, we can see no acoustic shadowing. And let's see what happens when we change the position of the patient. The tumor remains on this segment of the wall. Even when I try to bounce the gallbladder, it remains in this region. We continue with the issue of bile duct. Bile flows through the bile ducts in the liver into the hepatic bile duct. This joins with the cystic duct to form the common bile duct over here. And this is the structure we have to measure during every examination. It should have a diameter up to 6 millimeters in young and healthy patients. If the gallbladder has already been removed, it should be less than 10 millimeters. Keep in mind, common bile duct 6 millimeters or less than 10 millimeters. The common hepatic duct should not exceed 4 to 5 millimeters. Intrahepatic ducts are not visible. This is very important. In the case of dilated bile ducts, it's absolutely essential to localize the pathology. We have to answer the following questions. Is the common bile duct dilated? Are the bile ducts in the liver dilated? Are there any gallstones? Is a gallstone visible in the common bile duct, or does a tumor exist? For this purpose, we identify the common bile duct along the portal vein. Almost always it is situated above the vein, where we do the scan in this region, over here, and on our sonographic image we see this area of interest, the region of interest over here, above the portal vein. The common bile duct follows the portal vein and runs along with the hepatic artery, and here we can do the measurements. It's below 6 millimeters and absolutely fine. So, when you want to assure that we scan the portal vein, we can use color Doppler. It doesn't matter where we see red or blue signals, but so we can be sure that this is the portal vein and we do not mix it up with the common bile duct. The second vessel in this plane is the IVC over here. So, once again, common bile duct, portal vein, IVC. In this view, we also see the gallbladder over here, and this tubular structure is the common bile duct. But what's about the hepatic duct? We look for the hepatic duct in a different view. We scan the porta hepatis. This is the area we have to scan. And on the sonographic image, this is the region of interest. So, our jumping deer is displayed on the screen. And superior to the branches of the portal vein, we see the hepatic bile ducts. So the bile ducts right on the jumping deer. Clearly the diameter is less than 5 millimeters, so no biliary obstruction. I'm sure you know the measurements already, but here they are once again. What is the cause of biliary obstruction? Mostly stones in the distal bile duct, but sometimes an even small tumor blocks the drainage of the bile. So in case of jaundice, we look carefully for tumors in the hepatic bile duct, the common bile duct, and most distal in the pancreas. Quite rare are other diseases like sclerosing cholangitis or biliary atresia that lead to dilated bile ducts. But let's look for the location of the blockage of the bile ducts. When we are concerned with dilated bile ducts, we look for the level of obstruction. If the level is intrahepatic, bile ducts are dilated, so the bile ducts anterior to the portal veins are dilated, and the common hepatic duct and common bile duct are normal in size. If the location is extrahepatic and distal, also the common bile duct and the hepatic duct are dilated. So, what are the reasons? I already told you. Tumors in the bile duct, sclerosing cholangitis, maybe also Caroli disease when the location is intrahepatic and extrahepatic. Also the chronic pancreatitis is one of the reasons for dilated bile ducts. Now let's see what's wrong over here. There are more structures that we have seen before. There are bile ducts seen over here. Don't they look like branches of an old tree? I think so. And in the loop, you can clearly see these tubular structures over here following the portal veins. I will show you the clip once again. In this area and over here, there are bile ducts, intrahepatic. And there you see the double channel sign, or the so-called double barrel shotgun sign. These two tubular structures over here and here are indication for dilated bile ducts intrahepatic. So remember, when you see double channel sign or double barrel shotgun sign, this is an evidence of dilated bile ducts. But what is the reason for this dilatation, for this obstruction? When we scan the portal vein, we see a common bile duct of a tremendous diameter. It's nearly 20 millimeters. So, in the next clip, we see the reason. It's a huge pancreatic carcinoma which blocks the drainage of the bile and causes these signs of biliary obstruction. A sad case indeed. Here, another case of biliary obstruction in an elderly man who lost over 15 kilos of weight in the last 6 months. You see these tremendous dilated bile ducts. There's no Doppler sign in. They're not vessels. These are bile ducts. And you see this dilated common bile duct over here. Portal vein over here. And common bile duct superior to the portal vein. But what's the reason? We couldn't find it in our ultrasound examination, so we performed another image modality and found gallstones in the very distal common bile duct. And I'll show you this over here. Common bile duct and a lot of concrements in there, blocking the drainage of the common bile duct. So in this case, there was no malignant tumor, only some gallstones. So to summarize, we learned how to find the bile ducts, what the measurements are. We have seen double barrel shotgun sign, and we know it's very important to find the localization of obstruction when the patient has got jaundice. So it's time for a break, but we will come back with the next chapter.